Hello, this is Mirrakhimov speaking. I'm one of the cardiac anesthesiologists at the University of Kentucky, and today we'll be talking about perioperative anaphylaxis. I have no conflict of interest in regards to this presentation. Please take a second to look at the disclaimer for this presentation. So the agenda for our today's talk will include discussion of epidemiology, risk factors, a word or two on basic science, common culprits, clinical presentation, immediate management, and diagnosis. Because anaphylaxis is truly an acute and emergent condition, the diagnosis should occur after the immediate treatment and patient stabilization takes place. Let's do a question. Which patient is at increased risk for perioperative anaphylaxis? A 21-year-old female who has a history of metabolic syndrome, and she is scheduled for laparoscopic cholecystectomy. A 35-year-old male with history of high blood pressure managed with amlodipine, who is scheduled for shoulder surgery. And 25-year-old female with history of bronchial asthma and atopic dermatitis, who is scheduled to undergo cesarean section. Please take a second to think of your answer. And the correct answer here is a 25-year-old female with history of bronchial asthma and atopic dermatitis. And we'll touch base on this a little bit more, but basically a patient who has allergic disease, such as most patients with bronchial asthma do, and atopic dermatitis are considered to be high risk for anaphylaxis. As you can see on this slide, anaphylaxis is a relatively rare condition. However, it definitely has a very high morbidity and the potential for mortality. Up to 2% of all anaphylaxis cases, which include perioperative and non-perioperative anaphylaxis, are fatal. Unfortunately, perioperative anaphylaxis mortality range is slightly higher than for general population and can reach up to 5%. On the bottom right of the screen, you have some references to the original papers, which quote these findings. So what are the risk factors for anaphylaxis? So obviously history of previous anaphylaxis, history of allergic diseases such as atopic dermatitis, for example, and bronchial asthma, like in the question described earlier. Patients who have history of multiple previous surgeries, probably due to higher rates of sensitization to possible allergens, such as medications, for example, are at high risk for perioperative anaphylaxis. And also patients who have mast cell disorders are considered to be high risk for anaphylaxis in general. So, what are the risk factors for severe and fatal anaphylaxis in general? Patients who have a higher American Society of Anesthesiology class or ASA class, patients who take certain medications such as beta blockers and ACE inhibitors, and patients who are obese. Patients who have higher ASA class may have less reserve to tolerate the hypotensive response of anaphylaxis reaction, and patients who take beta blockers may have a decreased response to epinephrine. Patients who take ACE inhibitors may have a higher propensity to profound vasodilatory shock, as seen in anaphylaxis, due to use of ACE inhibitors, which are antihypertensive agents. On a chemical and immunological level, the reactions can be broken down into two main groups. The first being immunologic reactions, which are mediated by IgE and IgG antibodies. These reactions usually require previous exposure or sensitization to an allergen. The second type is called non-immunologic, which is a result of direct stimulation of mast cells and basophils, which lead to release of chemicals such as histamine, among many others. For the treatment purposes, the management of those reactions is similar. On this slide, you see the most common causes of perioperative anaphylaxis, including antibiotics such as cephalosporins and penicillins, prochloronium, succinylcholine, chlorhexidine, certain dyes such as methylene blue, latex, Sogamidex, protamine, and certain colloids have a high risk of anaphylaxis, which typically contain gelatin. Thankfully, these colloids containing gelatin are not available in the US. So what about the causes of anaphylaxis in the general population? Since we don't live exclusively in the operating room, I think it's important for us to know that. Obviously food, including peanut, tree nut, crustaceans, and food additives. Insect stings and bites, latex as well, medications such as antibiotics, opioids, non-steroidal anti-inflammatory medications, contrast agents, even exercise and extreme temperature, cold and heat can lead to anaphylaxis. So what about the diagnosis of anaphylaxis? Again, anaphylaxis is primarily a clinical diagnosis. This table is taken from the 2006 guideline published jointly by the National Institute of Allergy and Infectious Disease and Food Allergy and Anaphylaxis Network. Please take a second to review the table. Again, strongly suspect anaphylaxis in the right clinical setting when there is an acute onset of illness, typically within minutes to hours, with skin, respiratory, cardiovascular, and gastrointestinal manifestations, such as stridor, hypoxemia, wheezing, angioedema, hypotension, rash, such as hives or urticaria, and nausea, vomiting, and cramping abdominal pain. So let's take a look at some of the clinical signs of anaphylaxis. Here you see a rash, commonly described as hives or urticarial rash. It is typically associated with itching and clinically feels as erased over the skin. Next two pictures represent angioedema, which is a swelling of the face, lips, tongue, and upper airway. And obviously for us anesthesiologists, this may be a very challenging situation to secure the airway when necessary. So what about the diagnostic approach to perioperative or intraoperative anaphylaxis? Unfortunately, the recognition may be delayed. And why is that? Our patients are often under general anesthesia or some sort of sedation and may not be able to relay any concerns or symptoms he or she may be having. Quite often, the hypotension can be attributed to deep states of anesthesia or too much anesthesia being given, and tachycardia quite often can be attributed to light planes of anesthesia. Obviously, bronchospasm, skin manifestation should raise your suspicion quite significantly, and overall we have a very low threshold of suspecting anaphylaxis in the right clinical setting, such as, for example, after administration of a certain chemical, antibiotic, or new medication to the patient. So what about the timing of intraoperative anaphylaxis? I think it follows the time frame when we typically give certain medications. So early onset, which is typically within 30 minutes of induction, think about antibiotics you gave or neuromuscular blocking agents. Mid in the case, typically think about latex allergy, blood transfusion or colloid volume expander use if you gave it to the patient, and obviously administration of dyes to the patient if they were given. Late onset is typically towards the end of the case or in the PACU, and again, what medication we typically give to the patient at that time, I usually think of Sugammadex or neuromuscular reversal. So what about the patterns of anaphylaxis? There are several. The most common one is uniphasic, which means that after successful treatment of the reaction, it doesn't recur. Biphasic reaction, which is present in less than 5% of cases, is the one which recurs within 48 hours after the successful treatment of the first initial episode. Protracted anaphylaxis is an anaphylaxis which somewhat responds to treatment but never fully goes away, or allergic reactions never fully go away. And refractory anaphylaxis is considered to be the anaphylaxis which doesn't respond to appropriate treatment, including at least 3 doses of epinephrine. So what to do in the case of suspected anaphylaxis? Obviously, a clear communication with the surgical team or procedure team, circulating nurse is essential. Cease and stop the administration of the agent you think is responsible. Prompt administration of epinephrine is vital to the successful treatment of anaphylaxis. Again, most of our patients in the operating room will have an intravenous line, so consider giving 10 to 100 micrograms of intravenous epinephrine. Follow a CLS protocol. Other medications are never the substitute for an epinephrine and should only be considered after epinephrine is given. They include steroids, beta-2 agonists such as albuterol, for example, H1 blockers such as diphenhydramine, and H2 blockers such as famotidine. Again, the data supporting the use of this additional medication is overall quite weak, and unfortunately the only medication which is associated with improved morbidity and mortality of anaphylaxis is epinephrine. So never shy away from giving epinephrine if you think the patient has anaphylaxis. As mentioned above, we do not live within the operating room environment exclusively, and sometimes you will be responsible for providing care to the patient who has no IV access, whether in the hospital or outside of the hospital. In such cases, you give intramuscular epinephrine. Typical dose is 300 to 500 micrograms or 0.3 to 0.5 milligrams, and you usually give it into the mid-outer thigh, and obviously as soon as possible, if resources allow, ensure vascular or intraosseous access for further resuscitation. So let's review a case. You're taking care of a 58-year-old gentleman who has a history of coronary disease, hypertension on metoprolol and amlodipine, who is getting his shoulder arthroplasty in the operating room. He was induced and intubated without any issues. Within 2 minutes of IV cefazole administration, the patient's heart rate increased to 160 and the blood pressure dropped to 50/30. Tidal volumes on the ventilator dropped from 500 cc's to 50 cc's on the volume control mode with a peak pressure of 50 millimeters of mercury. You suspected anaphylaxis and started giving epinephrine. You gave 50 micrograms doses times 3 with minimal to no improvement. And what medications should be considered next? Next is phenylephrine, vasopressin, glucagon, or ondansetron? And we'll answer this question in the next slide. So what about glucagon? It should be considered in patients who are taking beta blockers and who are not responding appropriately to epinephrine. The typical dose of glucagon for this indication is 1 to 5 milligram IV bolus given over at least 5 minutes. And if needed, you can continue with 5 to 15 micrograms per minute continuous infusion. And obviously, if you give this medication too fast, it can lead to nausea and vomiting, which can be quite problematic in certain patients who especially have decreased sensorium or at high risk for aspiration. For patients with refractory anaphylaxis or in patients who are not responding appropriately to epinephrine, one must ensure that the contact with culprit agent is definitely stopped. Make sure that you're giving epinephrine appropriately. Check your IV status. Make sure the IV you're using is a functional IV. Consider giving glucagon like described in the past. Additionally, think about other vasopressin agents such as norepinephrine, vasopressin, nitric oxide scavengers such as methylene blue and hydroxycobalamin can be considered in refractory cases as well. And in the most challenging cases, ECMO can be considered. So anaphylaxis is associated with less than 1% of deaths, which is still considered to be quite high. Unfortunately, delayed recognition and administration of epinephrine is one of the main risk factors for that. Patients who have cardiopulmonary disease, higher ASA class, and patients who are taking medications such as beta blockers and ACE inhibitors are considered to be at high risk for fatal anaphylaxis. This is likely due to a decreased reserve in addition to hypotensive response to anaphylaxis. Patients who are under anesthesia in our care are also considered to be at high risk for death because quite often we are taking care of a sicker population. We have somewhat delayed recognition due to the factors we mentioned earlier, and general anesthesia by itself or spinal anesthesia, for example, being used is associated with already vasodilated state. So another insult such as anaphylaxis may result in death in such instances. So what about whether to proceed or cancel the surgery or procedure? Obviously, it must be a patient-centered decision. You have to keep in mind how promptly the treatment was given and how fast the patient achieved hemodynamic stability. Obviously, some patients with elective surgery can be safely rescheduled, whereas some other patients with more urgent needs have a higher risk of delaying the surgery. So obviously talk to the patient, family, talk to the surgeon depending on the urgency, and make the best decision, keeping the patient's best interest in mind. So when things are settled and the patient is stable, consider sending a blood test called tryptase to the laboratory to confirm or refute the diagnosis of anaphylaxis. Ideally, you have to send this test within 30 minutes to 3 hours of the reaction. You need to use a red top tube as shown on this slide. The tryptase is somewhat specific chemical which is released by mast cells and basophils, which are considered to be key cells in the pathogenesis of allergic reactions and anaphylaxis. So let's talk about galactose alpha-1,3-galactose, also known as alpha-gal. Alpha-gal is a carbohydrate which is present in most mammals, excluding apes and humans. It is interesting to note that the majority of allergens are proteins. However, in a rare occasion, carbohydrates can act as allergens too, such as in the case of alpha-gal. Classically, it is present in the red meat, gelatin-containing medications, bovine extracts, and it typically leads to delayed onset reactions such as hives, bronchospasm, and fluoride anaphylaxis. When these alpha-gal containing medications or agents are given intravenously, these reactions can occur or happen at much earlier time. So what about the epidemiology of alpha-gal syndrome? The patients may be sensitized through the Lone Star ticks, which are present on the top right. The geography of alpha-gal syndrome in the United States is typically found in the southeastern states, and also exposure to cetuximab therapy, which is a newer agent used in colorectal cancer, head and neck cancer, and penile cancer, is associated with the development of alpha-gal syndrome. So what are the risk factors for alpha-gal syndrome? Residents in southeastern and eastern United States, exposure to Lone Star ticks, red meat sensitivity, sensitivity to cetuximab therapy, and patients who have non-B blood group types. Patients who have B blood group types, the B antigen on the red cells is very similar in its chemical composition to alpha-gal, explaining why patients who have B blood group types are at low risk for alpha-gal syndrome. So one might wonder, why does it matter to us anesthesiologists whether the patient has alpha-gal syndrome or not? That is because many medications we use in anesthetic practice are potentially unsafe to use in patients with alpha-gal syndrome due to certain additives and chemicals. On this table, I put the medications which I think we commonly use in anesthesia practice. For a more complete and thorough discussion of alpha-gal syndrome and anesthesia, I refer you to this article with a PMID reference number. Please take a second to review this table. So in summary, perioperative anaphylaxis is rare, but unfortunately carries a very high morbidity and mortality, and much higher than in general population of anaphylaxis patients. It is essential to timely recognize this reaction and promptly administer epinephrine and supportive treatment. Good intraoperative communication with the procedure team, surgical team, and circulator nurse is essential to favorable patient outcome. Thank you very much for listening to this presentation. Here's my email address if you have any questions or comments about the presentation. I wish you all the best and good luck.